Medical information on this site is provided as an information resource only and is not to be used or relied on for any diagnostic or treatment purposes. This information does not create any patient-physician relationship and should not be used as a substitute for professional diagnosis and treatment. Please consult your healthcare provider before making any healthcare decisions or for guidance about a specific medical condition. Doctors Ruhoy and Kaufman shall have no liability for any damages, loss, injury, or liability whatsoever suffered as a result of your reliance on the information contained in this site. Hi there, this is Unraveled again, and I'm Dr. Kaufman, David Kaufman, and I'm here with Eileen Ruhoy. We're back in the studio, which we are excited to be in. We haven't been here for a while. So we have nice lights and everything.
Better lights, better sound.
Right. So we are going to dive into a topic today, which I absolutely love. I find totally fascinating. I think it is the kind of foundational issue in ME/CFS, long COVID, chronic complex illness, infection-associated chronic illness, whichever acronym name you want to use. I'm going to use a paper that came out recently that is quite incredible and is a corollary to me, the flip side of a coin of the paper we talked about, Eileen and I talked about with T-cell exhaustion and the role of adrenaline catecholamines, stress, and the role of beta blockers. I don't know if people recall that episode, but so this is another paper on T-cell exhaustion. I will caution everybody that the biochemistry, the molecular science is way beyond me. All right, I can't follow a lot of this, but the fundamentals I do follow, and I think it's really critical because it's something that we see all the time in our daily clinical work, and that we're going to come back to that idea in a minute. So the name of this paper, which I had to write down here, to give you an idea of how crazy this gets, Transcriptional Reprogramming Primes CD8 positive T cells toward exhaustion in ME/CFS And we'll just dive into it.
Yeah, I mean, first of all, I think T-cell exhaustion seems to be the name of the game, right? And I think that, and we always talk about how we have been seeing this for years clinically, and then we all of a sudden see that scientists and other more basic science, even scientist clinicians are doing the research to sort of prove and describe in biochemical molecular terms what we see clinically and what we try to treat clinically. And what's so nice about that is that it almost, in many ways, confirms and supports and validates what we believe to be happening in our patients. And so it almost provides fodder for some of the treatment options that we try and offer. And I think that, and so it's exciting when a paper comes out that you're like, yes, this is what I've been seeing. This explains it better than I could have maybe. And so, I love that aspect, and I think that has to happen more. I think there has to be more conversation between clinicians
it's the
and
classic
scientists.
dichotomy of clinicians, clinical medicine, and bench medicine or basic science medicine, and it's a huge problem. It's still a huge problem in chronic fatigue work. It's been a huge problem since day one. The great labs out there, Stanford's lab, the genomics lab, Maureen Hansen, and the guy at Columbia. They're great doctors, great scientists, great labs, but sorry, they don't take care of patients, and they don't know what we know, just like I don't know what they know. And if we could link them closer, I think the speed of knowledge and achieving effective treatments would be quantum leap.
I completely agree with. I mean, I didn't mean to interrupt you, but I completely agree because you just sort of made me realize like how, we both get excited when we read these articles. So like our scientific mind, it's almost like it's inspiring, but then it almost doesn't compare to when we see our patients in their suffering, right? So it is a weird dichotomy. It's like academically we so appreciate that kind of work and that kind of science and support it and love it, but then every day we spend most of our days with patients who have been suffering for a really long time, and they have tried just about everything under the sun by the time they've come see us usually, and nothing really has helped in any significant manner, and the suffering is just undeniable and sometimes really like hard, and so it's nice when we start seeing papers come out that sort of at least, like I said earlier, like at least give some credence to not only what we're seeing, of course, but what we're doing for these patients.
I think we're getting slightly off topic, but I think it's I think it's one of the reasons that sometimes we, certainly I won't speak for you, come off kind of negatively about Project Recover and the NIH and everything, because I feel there's so much suffering and it's taking so long, and they just take forever to get going, and then they pretty much just reinvent the wheel. They haven't really taken advantage of a lot of the history of what we've all learned. And meanwhile, I can't wait. My patients can't wait. I'm not going to wait. I'm not going to ask a patient to wait 3 years for a trial to be completed.
Right.
And it's a very frustrating thing. Getting back to the paper for a second, I want to amplify something you said, okay? What we see, I'll speak for me, what I see in the course of taking care of patients is intuitively, based on seeing so many people, this idea that it's all about the immune system. That is what this is about. It's the immune system, baby. It is immunology. And over and over and over, I see that with our patients. And I do see, and I've talked about it, that it is based on chronic infections and reactivated infections and chipping away at the immune system. But I don't have the language and the science to fully explain that. And that's why I got so excited about this paper.
Right. But yeah.
Yeah. So just a quick summary of the paper. I can't do it that way. A quick point from the paper. Yeah. At the end of the day, when you get past all these diagrams, which are so hard to understand, and data points and ranges and language that I can't understand, at the end of the day, they're saying kind of what we're saying, or not saying, but what we see, but putting science to it. Putting the molecular knowledge to it, which is that chronic, repeated, antigenic stimulation, that means stimulation from bugs to the immune system, will lead to T-cell exhaustion.
Right.
And once that happens, you have a potentially a never-ending cascade of worse and worse and worse. Your immune system is less effective, so you have more antigenic stimulation, more reactivation. And there's another key, incredibly interesting piece in this. I'm sure that you, like me, have had many patients, especially, I don't know if I want to say especially long COVID, but many patients who don't have an infection etiology that we can determine, but they were or are, well, they were and are elite athletes, hyperactive athletes. If they're not competing at the elite level like a cyclist, they are still really they're out there all the time.
Yeah.
And they present the same way. And in this paper, they describe that role of stress and inflammation from that kind of activity leading to the same T-cell exhaustion. That's incredible.
No, it is incredible. I mean, I think that in the exercise physiology world, there's lots of papers to support that too much exercise is not necessarily a great thing.
Exactly.
And it's for those kinds of reasons. So it's nice to sort of see a finding support lots of other thoughts that we've had in different aspects of human health in general. Right. I do think we should, so let's just sort of take a step back. So antigenic stimulation. Right. So it doesn't necessarily mean viral persistence.
No.
Right. So an antigen is a piece of, in terms of infection, a piece of a bug that's basically presented to the B cells, for the most part, to make an antibody against that antigen. So the antigen is not necessarily a whole organism. It could be a fragment of the organism. It can also be, which is where autoimmune disorders come in, it can also be a fragment of a part of our cells, our tissues, one of the proteins that are in our bodies that. And sometimes, there's something called molecular mimicry where a certain virus or specifically a fragment or the antigen of that virus looks very much like a piece of our bodies. Right. And so there's this thought that molecular mimicry plays a role where the immune system gets confused. Right. And so it starts to make these antibodies that's meant to recognize that fragment of that organism, but instead it recognizes that same fragment in some cellular membrane of one of our cells, as an example, of course. There's lots of examples. And so that's where autoimmune disease is thought to stem from.
And that's one of the clear hypotheses for long COVID, that there's residual pieces of COVID virus hanging around.
Right.
And that's continuing to stimulate the immune system. And after a while, it just gets exhausted.
Right. And I'm actually starting to think it's more spike protein persistence as opposed to viral persistence, because there was that really interesting paper, which we should actually cover another episode, where they actually showed spike protein in the brainstem, and it's active. It's actually creating this antigenic stimulation.
Exactly. That's a great paper too.
It's a phenomenal paper. Right.
I was going to post that one on blue sky, but I didn't do it yet.
let's
I'm trying
cover
to
it.
learn how to do blue sky, God damn it.
You're good. You're getting good. You've got a lot of followers.
No, I have like 7 followers. I think.
You do not,
I
David.
don't even know how to read
You
it.
have like 140 or something.
You have to show me how to see
I think you have more than me. I don't know how to. I was able to get a Twitter follower, but I don't know how to get a blue sky following. We should cover it first, and then we can post it on Blue Sky. That's actually how we can use Blue Sky. Anyway, so yeah, so I could be wrong. I don't think there's a clear consensus yet. I know there's a lot of thought about viral persistence. Some of the research really is suggesting it's more of this antigen persistence, specifically the spike protein.
Right.
So who knows what ultimately will be. But I think it's important to sort of understand for those who aren't not doctors or scientists. So chronic antigenic stimulation seems to lead to this T cell exhaustion. Now the T cells themselves, of course, there are lots of different T cells. So there's the helper T cells, right, which are the ones that are basically antigen presenting cells, and there are other cells that play that role, but the helper T cells present the antigen to the B cells. And there are the cytotoxic T cells, which they have their own mechanisms of destroying a cell that's been infected or a cancer cell. In fact, there's a lot of T cell therapies for cancer. Then there are the regulatory T cells.
Tregs, yeah.
I think they just hang out.
Well, no, they help modulate the immune system and prevent the autoimmune response.
Regulating, right, exactly.
They're like a name of the game in some ways. Okay. A lot of the interactions or interventions that we discuss at other times, like rapamycin, in fact, increase Treg functionality.
Which is important, because they modulate.
Yeah.
And then is there any other kind of T cell?
Oh, there's so many.
Okay.
Yeah.
Well,
I don't think we want to go down that
no,
rabbit hole.
we
don't
know
know
but
enough.
I mean, the major classes is what I was thinking of, just sort of describing that there are different classes of T cells that are identified by markers on their membranes, like the CD markers.
I think you were making a very important point to clarify and amplify this paper and this concept. When we talk about antigenic stimulation leading to this problem, it isn't only viral infection or bacterial infection, reactivated or persistent, and everybody knows, we're talking about EBV and we're talking about tick-borne infections, et cetera. It's also, as in long COVID and what we're beginning to understand, it can be persistent COVID virus, but it's also can be persistent pieces of the virus and persistent spike protein. And there's fair amount of information that may well be true in Lyme disease, that the bug is gone, but pieces of the bug are still there, and that's what post-treatment Lyme disease might really be.
Right.
So the point I'm trying to make is that you don't need a live organism. What the issue is, whatever causes T cell stimulation potentially becomes a double-edged sword and can lead to this exhaustion.
That's a really important point, right? So sometimes we know that COVID, for example, does reactivate viruses. That's been shown. I think that there may be some evidence, but I certainly think we see it clinically where there seems to be activation of like chronic Lyme, for example.
I see so many long COVID patients. When I run the test, I take the history. Oh, yeah, I grew up in upstate New York, and I was covered in ticks, but I never got sick. I never took medicine. Nobody ever tested me. I've been fine my whole life till long COVID. And then I test them, and they have Babesia, Bartonella, and Borrelia. Now, that's reactivation. That is not leftover antibody. These are we're seeing the organisms under the microscope. So that's a clear example of reactivation in the face of immune disturbance caused by COVID.
Right, and that's the other point. So it could reactivate an actual infection, which I'm presuming that because with the immunofluorescence, you're actually seeing the bacterium.
Yeah, you see it, right.
But let's assume that there was even just a band of one of those, which is how some of the testings are done, which is just a fragment. If there is immune dysregulation and there's activation of the immune system, specifically, the adaptive immune system, which is where the T cells sort of lie, then there could potentially be a response to that fragment or that band that's sitting there, or any antigen of even a virus, the EBV, the CMV, the HSV, HHV. These can all be just fragments that were probably just sort of sitting around doing nothing and may have done nothing for the rest of the patient's life. But now the immune system has been so dysregulated by COVID, for example, just speaking of the long COVID patients, that now even those fragments are creating further antigenic stimulation of these T cells.
Again, it's this whole idea that we've talked about in terms of septad, but it's true in terms of pathology. All of this interactivity, okay? you may have the pieces on the puzzle board and they're not doing anything, and then along comes an immune dysfunction, and all of a sudden those pieces start moving around and interacting with each other and causing total chaos and causing a cascade of event after event after event.
Yeah, I love the way you described that. That was perfect. And that does lead to what has been referred to now as T-cell exhaustion, which I smile at that name all the time because I'm like, why are they so exhausted?
Right. Well, I mean, I confess I have, my own nostalgic's not the right word, but nostalgic interest, because in HIV disease, it wasn't a CD8 cell, baby. It was a CD4 cell.
That's right.
And as they went down, those poor patients just crashed and burned.
I know.
And that wasn't exhaustion. That was true direct viral destruction of the CD4 cells. But as the cells went down, their immune system got worse. And then it was, excuse me, the same cascade of events. They have an immune system that becomes progressively dysfunctional, especially CD4s. And then they start getting these wildly esoteric infections or things that would never cause anybody to be sick.
Right. That's such an interesting part of HIV versus what we see in long COVID. But I interrupted you, so go ahead.
No. So it is different, but it's similar in the sense that the CD8s are not exhausted, we don't think, from direct viral destruction. It's from trying to destroy the virus.
Right.
Okay. So it's I was, before we started today, and actually early this morning, I was thinking about this episode, and one of the models I was thinking of was putting it into the war games battle language that's often used in medicine, right? And so you have this exposure to virus, whether it's COVID or reactivated EBV, and the immune system goes into action, and it keeps trying to fight and kill those bugs or make them latent and stationary phase, and it keeps going on, and they run out of troops.
Yeah, that's right.
It's like Ukraine; they're running out of troops.
That's exactly right. I think that war is over now.
No, it will be on January 21st, probably.
God. Right. I just find the term exhaustion, like, I can't help but think of, when I was growing up, my Jewish mother, why are you so exhausted? Because I was always saying that I was tired. And then there's that funny song from that movie Blazing Saddles. Remember that movie?
Yeah, sure.
What a funny movie.
Hysterical.
And I forget the name of her actress. I know her first name was Madeline, but she sang that song like, I'm tired of being admired. And then she says, I'm exhausted. And so every time I see T-cell exhaustion, I think of her song and that performance in that movie. But regardless, the T-cells are exhausted, and it is from chronic antigenic stimulation for sure. And I think, and so what does that mean? So T-cell exhaustion means that they're producing and secreting fewer cytokines. They have increased expression of inhibitory markers on their membranes, so they don't work as well because they're basically putting up walls, like no more, can't do anymore. We're out, we're closed for the evening.
We're done.
We're done. Right, and their effector functions are just decreased. So you basically are left without T-cell protection. And the T-cells, of course, which, they generally mature in the thymus. We don't have a thymus any longer. So it's hard for an adult body, I should say, to replenish and to recover. Right. So the thymus, which is a gland that involutes as we age, though sometimes on imaging you could see some remnants of it, but for the most part it involutes, and it doesn't have its function as it did when we were younger and when we were kids, where it was helping the T cells mature and differentiate. So the adult body has a difficult time recovering from T-cell exhaustion. And other research also shows that T-cells are exhausted most severely, or I don't know what the right word is, but in a hypoxic state, which to me is a fascinating finding, right? Because then we talk about the microclot theory, right? And we do a whole
connected.
Yeah, it's all connected. And I honestly think that this is the root of the cell danger response, right? So it's this vicious cycle.
I was just going to bring up cell danger response,
right?
The way you were presenting the T-cell issue.
I think we're actually sort of illuminating what the cell danger response is, and of course Bob Nevio did a phenomenal job at coining it and describing it. But there's still a lot we don't understand, and there's still a lot we don't know, and yet we apply it to our patients, And so it was fascinating to me. For last couple of weeks, I've been really trying to catch up on some of the research with regard to the immune system and COVID, and just because of the patients I've been seeing. So that's what's interesting to me about the practice is it's not just academically, I want to learn more. I want to learn more so I can help more.
Right. You want to help tomorrow.
Yeah, I want to help.
Not
That's
next
exactly
year,
right.
tomorrow.
Right. You see these patients suffering, and it's like, I don't know the answer to this, and I have to look it up, and I end up going down those rabbit holes that we talk about, all the tabs that you always describe, trying to really put the pieces of the puzzle together for an individual patient.
Right.
And to me, I love that kind of work, right?
Yeah, that's why I'm
like,
doing
it's,
this.
it's not like just sort of this generic, like, I just want to learn about this so I can pontificate, over a dinner party.
Yeah.
I want to really help like a human being that has come to me for help. So I don't know how I got off on that tangent, but my point is that, so I've been reading about all these different pieces of research that are sort of showing that in a hypoxic state, you have further and worsening T cell exhaustion because it ends up leading to mitochondrial dysfunction. I hate to sound like a one-show pony, but it's true. I mean, everything comes back to the mitochondria.
Including the immune dysfunction that I'm talking about. That is still mitochondrial based.
Absolutely. And so there's more, and that's another thing that I think is an important point. So when there's a hypoxic state, the mitochondria start to falter, and they actually go from, they basically revert to glycolysis, which is maybe why the aldolase is always so slightly low. But anyway, regardless, but it reverts to a glycolysis. It produces more reactive oxygen species, and it actually upturns its electron transport chain function. So when we have talked about, we're off topic. We're on like a different topic at this point.
No, it's all
when
related.
we have talked about sermon in the past, we talked about how its only mechanism of action is to help block the extracellular ATP, which to a lot of patients, when I'm trying to describe it, well, if the mitochondria aren't working, doesn't it make less ATP? It doesn't. There's a change of the rapidity of the chain in which it chugs along, and so there's excessive ATP that is just not utilized. It's extruded from the cell, and that's how it becomes extracellular. But regardless, what sermon is, I don't know where sermon stands. So, so there's mitochondrial dysfunction, and there's greater reactive oxygen species, and that puts greater burden on these T cells, and now they're just even more exhausted.
Right. So I think, going back to what you're saying also about CD8. So as the CD8 become exhausted, again, I hate to be a broken record also, but it brings me back to the CD4 and the HIV diseases, okay? The opportunistic infections in HIV disease. So in CD8, in CD8 or T cell exhaustion in the patients we're talking about, as that occurs, it creates this cascade because things only get worse, right? They don't get worse in a straight line. They get worse the way patients tell us it gets worse, which is like this, and then they're a little better, and then this, or they might even be a little better for years, for 3 years. And then they get a cold and they crash.
Right.
What kind of crap is that? That makes no sense unless you start putting it in this context of their immune system is already disturbed. It tries to recover. We have extraordinary bodies. We try to recover, but each time we get chipped at, it's the multi-hit theory. Also, I think we've talked about that.
Yeah, I know.
So
it
hit one,
is.
You're 14 and you get EBV and you get mono. You're actually sick. We all get EBV. Most of us never get sick. So you get knocked down a little, but you recover. You go off to college. You drink a lot. You do other things you shouldn't do, and that further may injure your immune system. Then you get a cold, and that might knock you down. Then you get reactivation of your EBV. It can always reactivate, and each hit knocks you down. The T cells get more and more exhausted until that you are stuck. You are down here and stuck, and this paper and this concept helps put it into a context that makes a lot of sense.
I agree.
So the challenge, like HIV disease, how do we get those goddamn CD4 cells or CD8 cells back up? Okay?
Yeah.
And for me and for you as clinicians, that's what matters.
Oh, that's all that matters.
So I don't know if we want to shift into that.
Yeah, no, I mean, I think
piece of this.
We should just wrap.
Okay. So for me, I am absolutely biased about infectious disease. It's what I look for in every patient. And I want to broaden that concept or term. I don't just mean EBV, human herpes virus 6, HHV6, HHV7, which I'm finding more and more. The more I look, the more I find it. And tick-borne infections, the big 800-pound gorilla are these guys.
Yeah.
Okay.
Oh my God!
Trillions of bugs in our microbiome, and then they are keeping us alive as a species. But if we have the wrong bugs down there, wrong change in population, or perhaps more importantly, injury to the gut wall, so you have translocation, meaning leaky gut or increased permeability, which, by the way, was a huge issue in HIV disease. I'm trying to make these connections on purpose, not just because I'm
useful
obsessed
for
with it.
not only me, but I'm sure our listeners, because you have all that experience.
So think about the antigenic stimulus from the gut and translocation. It is overwhelming.
Overwhelming.
It makes EBV reactivation look like a walk in the park because it's going on constantly every day. And it's one of the reasons I get nuts about SIBO with my patients and in these kinds of conversations. When I have a patient who describes, oh yeah, I've had gas and bloating and constipation, alternating diarrhea since I was 7 years old. And I hear that all the time. If you ask, you will hear it.
Yep.
If you don't ask, you're not going to hear it, okay?
Well, because people just start to think it's normal. Yeah.
So for me, that means almost for sure, and then we prove it with testing, they probably had leaky gut for the last 25 years. Think about the antigenic stimulation, the assault on the immune system of 25 years of leak. And what's leaking is this lipopolysaccharide, LPS, which is profoundly toxic and immunostimulating. It's what's used as a sepsis model in the lab.
Wow.
So little bits over and over and over and over. At some point, people crash and burn.
So so when you have patients who tell you that they've had 20 years of constipation, what do you do? And by the way, I want to say that a lot of neurodegenerative disorders are known to have, these patients have had decades history of constipation. Right. And we just always just sort of made note of it. We never talked about it in neurology. We never talked about its contribution.
We're only just starting to recognize it,
Well, we've known for a long time that constipation was part of their history. But
recognize this
how
profound role of the microbiome
right.
and the gut-body
right.
connection.
So what's the first thing that you do when they tell you that they've had this very long history of GI stuff?
Well, I do SIBO testing for one thing.
Right. Well, yeah. I mean, and we've done,
and I treat quite aggressively, what I regard as aggressively, and try to make it clear that unless we can fix that constipation, they're never going to get rid of their SIBO and therefore never get rid of their leaky gut.
And so how do we fix constipation? So we start with the low-hanging fruit, of course, initially.
Yeah, initially I'll give magnesium oxide and
Linzess.
Change the diet. I almost never use Linzess.
Oh, really? Okay.
Yeah. Alter their diet and more fluids and more fiber, all the sort of usual stuff.
Do you find that dietary interventions helps early on? Yeah,
Not
I agree.
people.
I haven't found it to be helpful. I mean, I still guide them, because it's important, but I don't think it changes their constipation or it certainly doesn't change their bowel habits.
Motegrity, prucalopride, is a motility drug, so that works great. Unfortunately, it costs a fortune, so everybody has to buy it from Canada. Drives me crazy. Pyridostigmine, which is, what pyridostigmine is. But one of the great benefits of pyridostigmine is that it actually helps with constipation, helps with gut motility. I've actually started playing around with Reglan again, metoclopramide, old drug. Everybody's afraid of it because of tardive dyskinesia.
Yeah.
It's like rapamycin. Everybody just thinks it's transplant, it's immunosuppressive, so they won't even think about it. So that's Reglan. Using Reglan in low doses can be incredibly helpful with motility, with early satiety, with nausea and vomiting.
Have you ever seen tardive dyskinesia?
No.
Yeah.
I mean,
I've seen it. Yeah, no, I know.
Yeah,
I didn't.
I meant from Reglan. No.
The question.
And I was just like other docs. I was afraid of it, and then I just realized I had one patient. I had nothing left to try, and I said, "Well, let's just try this." And it was like, "Wow!" She got back to me and said it was great.
Yeah, I think it's a great drug, and I agree with you. The TD component always scares. I mean, including me sometimes. But I've used it at low dosages for short periods of time, and I haven't seen any patient develop TD on it from my use, from my prescription. But obviously, it's not uncommon, though.
But
I always say that certain side effects, like I say, yes, it's been reported in the literature, but I've never seen it in my career, and I don't know anyone who's seen it, actually, but it's been reported, so we all worry about it. But with the TD and the Reglan, I mean, I know of people who have developed it from Reglan, so I think it's a common concern, but yet, if you use it appropriately and for a short term just to get your bowels moving, I think it's actually very useful.
So, just to finish the SIBO piece, because I want to steer back the other way for a minute. So like I said, it's easy to kill the bugs that cause leaky gut.
Yeah.
And I have my own recipe or protocol to try to prevent recurrence and heal the gut, but I don't know if it's right or the best. And that's a piece of research that's desperately needed.
Yeah.
We need a protocol with 3 or 4 arms trying different supplements, different mucosa, fuel for the mucosa in the gut, to help them heal. We don't really know. We think we know.
Right.
But there's very little trial data to show and try to prove it. And that's like, if you think about this concept of T cell exhaustion from antigenic stimulation,
you have to
hey,
fix
it's
the
right there in
microbiome.
front of us. Let's go after that.
Have you been trying that inulin product with the probiotics?
I just started, yeah.
Yeah, so have I.
That's a whole other talk, I think.
Yeah, well, and how we know about it, it's a whole other talk.
Yeah.
But just in terms of that particular
Yeah.
product,
Yeah.
I have started to recommend it to patients with.
Have you heard any results?
Well, one who has a long history of recurrent SIBO, which I'm sort of curious about why that happens from your perspective, but literally has been treated like no fewer than 5, 6, 7 times with the antibiotics, and it just keeps coming back.
Yeah.
I recommended this product to him, and 3 weeks later, he says that his stomach feels better. And, again, it's an N of 1, and I haven't yet seen him in an appointment, so I don't know specifically what that means, but he wrote that portal message, so that his stomach all of a sudden felt he had no symptoms after he ate
That's
meals,
really
which
interesting.
was his common, it was more postprandial kind of concerns. But yeah, so anyway, so that might be something that we continue to do. And, inulin has long held like some star status in medicine.
Star status, but mostly ignored.
Ignored, yeah.
I
Yeah,
mean,
you learn about it in medical school.
Yeah, and then nobody uses it.
And nobody talks about it again. And every time I would go to the store and buy sunchokes or Jerusalem artichokes, I would think about the inulin. And I would, just because of medical school. And I was like, why don't, we should all be eating sunchokes then, right? So anyway.
So I want to... I don't want to lose what you're saying, but
I have a
think
lot
it
to
should
say.
be
Are
probably
you
a
kidding?
separate episode.
Yeah,
with the
I
whole
never stop
growth hormone
talking.
thing. Okay, so antigenic stimuli.
Yeah, so and you bring up a good point, right? So we can always say, oh, well, you had mononucleosis, oh, you had COVID 3 times, or pick your choice of viral infection. But the truth is, the most potent area where antigenic stimulation comes from is right in our guts, right? So, don't forget the GI tract, it's mouth to anus, it's exposed to the environment, and we eat things every day, we drink things every day.
Wow, I just had a thought. Okay. Sorry.
Was it my use of the word anus?
No. No, I'm not sure. Something you said that really just clicked, because at some point in this conversation today, I wanted to say, all right, you guys, Kaufman and Ruhoy, you've said a lot of BS and a lot of stuff, but you haven't answered the question. How come I'm sick and he's not?
Oh.
Okay.
Yeah, why
So I'll come back to that. That's the big question.
Oh, I love that question.
But part of the answer might be, so 90+% of the world has EBV from childhood. 90% of the world has HHV6. I'm beginning to think truly, and I know I'm going to sound like a lunatic, that 70% of the world has latent tick-borne infection, and especially Bartonella, which has got a widespread presence across countries, across the world, across animal species, across vectors. I mean, it's beyond huge, okay? But they don't get sick. And maybe what pushes the group that does get sick over the edge is SIBO and leaky gut, and that antigenic stimulation, which then causes this problem with the immune system, chronic inflammation, T-cell exhaustion, and then once that happens, those guys break out of jail and say, whoa, there's no more immune system, I'm going to replicate. And they go crazy, and the patient just goes down the tube.
So are you suggesting that T-cell...
I don't know, I just thought
No,
of it.
well, it's a really intriguing thought. But it almost implies that T-cell exhaustion happens way earlier than maybe clinically they present. Like there's some level of T-cell exhaustion where it opens the gates for these other antigens.
Okay, that was another 5:30 this morning thought. Okay, I'm serious. I really was up. I couldn't go back to sleep. I kept thinking about this talk.
See how excited we are to give you all this knowledge.
So when you read the paper and you discuss this in scientific circles and basic science people, it sounds like something that happens quickly. It doesn't.
Yeah.
And I know I'm going to get people bored and disgusted with me. And again, the connection I made was to HIV. When you get HIV infected, it takes 7 years for your CD4 count to fall to the level you might have a
I never
problem.
knew that.
7 years. That's the average time.
Really?
Yes. Okay. So 7 years of HIV
So by the time they would come to
replication.
your clinic, they had been infected.
Well, in the beginning, they had been infected for 7 years, but people then realized the problem, so they would test early.
Test early, got it. Okay, wow.
But there was lots of evidence.
I didn't know 7 years.
Unless it's changed since then. I don't do much HIV. I don't do any HIV now, but I don't think it's changed. So my point is, you have this virus, this evil virus, human immunodeficiency virus, and it is eating up your CD4 cells, but it takes 7 years to eat enough to put you at risk for all these opportunistic infections. That makes sense when you ask the question in our patient population, why does it take so long for them to get sick? Why do they say, give you a history where it sounds like something was kind of happening a little bit in teenagehood and young adulthood, and then they'd say, well, I always felt a little fatigue, and then I was a little more fatigued, and once in a while I'd be a little dizzy. Occasionally I'd have a funny allergic reaction. And it's just, they're sort of just puttering along, maybe down the hill slightly, and then all of a sudden they fall off a cliff, just like OIs in HIV disease.
Wow.
And my point is, I don't actually know if
that's
that's
profound.
true with the T cells, but I think it's true. And
No, it's really important because we always say, and we've said many times in our episodes, that we take this extensive history because you can always find signs early in childhood that they were at least set up for what they're suffering with now.
Right.
And we were often referring to mast cell activation,
right.
which is certainly part of the immune response.
It's a marker for this whole
Right.
thing. So if what we're saying is true, what I just talked about, that becomes a key clinical pearl because, surprise, drum roll, early intervention might prevent the cliff from coming up, from falling off the cliff. Because if you get to them before they hit that point, there's a greater chance of helping them, just like in HIV disease. If I have an HIV patient who comes in with 350 T cells, I know their opportunistic infection risk is not actually very big, but I know they're headed for deep stuff, okay? And if I give them treatment, which we finally had, those T cells will go up and they're going to be fine. They'll be fine. And I have patients still 35 years later that are alive because they got treated early enough before the opportunistic infections hit them.
Right. And we do know that early intervention helps more so than once you've passed a certain point.
Right.
It's hard to sort of recoup. And it's also what's so frustrating about so many patients going to see doctors who are just gaslit or, not validated because that window of what is considered early intervention, which can't define, and I think it's probably inter-individual variability, but that window starts to close if you can't find a doctor to sort of recognize what might be going on, what might be happening, and then intervene.
Or the window can be open wider.
Right, exactly. You can actually prolong the window.
What they're doing,
That's an excellent point, for sure.
So I want to keep going. Should we make this just a long episode?
Yeah, a long episode.
Right.
Let's go.
Is that okay? You with us still?
Anyone fall asleep?
All right. So let's talk about other antigenic stimuli.
Oh, gosh. Okay.
What does it mean in clinical practice when I have a patient sitting across the desk or more commonly on a display? Looking aggressively, vigorously, robustly for signs of infection.
Yeah.
And the challenge for a physician, for us, is not just signs, because we can do antibody studies and see those signs, but should we respond to those signs? Meaning, if they're only antibody positive, IgG antibody positive or something, does that mean we should treat it? And in general, I would say in general in medicine, in infectious disease medicine at any rate, if you have symptoms consistent with the diagnosis of pneumonia and you have mycoplasma IgG positivity, you would say, oh, this person has mycoplasma pneumonia and give them doxycycline or whatever. The question is, if they have no symptoms and haven't had any symptoms for 6 months and they have IgG levels, does that mean we should treat that? I generally don't. But this article has made me think maybe I'm a little too conservative.
Yeah.
I will obviously jump in on viral infections like EBV, although I still prefer to have evidence of reactivation, not just antibodies.
How do you find evidence of reactivation?
Usually either a PCR or a high early antigen.
Right.
But again, I wonder if in the same way that you and I prescribe LDN at the first visit, kind of like automatically, I don't know if you do what I do, automatically, maybe we need to have a much lower threshold for trials of antivirals, regardless of the evidence and whether it's good or bad for reactivation. Should every patient be put on a trial of Valtrex or Valcyte?
Well, that was my next question. So is it always just an option of Valcyte or Valtrex? I mean, I know that last time we briefly talked about ritonavir, for example.
Well, for the herpes family, I would say it's usually, it can be any of them.
Right. I mean, yeah.
Including tenofovir now, which is an old HIV drug.
Exactly. I just recently saw a paper about using that one. Yeah.
So ritonavir, just for people if they're not sure, ritonavir is part of Paxlovid, and again, comes out of the HIV era. I can't believe how much we're doing HIV. It was discovered in HIV disease that 6 pills twice a day, ritonavir had potent antiviral action, but nobody could tolerate that. It was like taking poison. What they really discovered is that 1 pill twice a day turbocharged the other antivirals because it changed the metabolism in the liver. So that's the way it's used in Paxlovid. What you're referring to is something I don't think we've discussed on the shows, but I talked to you about, which is I don't want to say discovery, that Recover, the NIH Recover, did a trial with Paxlovid for long COVID for whatever it was, let's say 3 weeks, I don't remember. And the placebo arm, because Recover will only do placebo trials, that's another conversation to have, okay? The placebo arm, ready, drum roll, was ritonavir. How screwed up is that, okay? They use an antiviral as the placebo. But I have a patient who was in the trial, and she got all better. And then they broke the code, and she was on ritonavir.
Oh, wow.
And now she stays on ritonavir, and it's been helpful. I can't explain it. 100 twice a day of ritonavir should not do that, but it is. Maybe it's doing something else in the with the enzymes and increasing activity of some other product. I just don't know.
Right. Well, similar with some of those monoclonal antibodies. I mean, some people report, like, in fact, we know of someone who's had his long COVID was resolved by one of the, which is no longer available, of course, in this country.
Right. But we may do a trial with
We're going to do a trial. No, we're going to do a trial with another one.
No, that's the one he took, I think.
No.
No?
No, the one he took is no longer FDA approved.
That's Evusheld?
Yeah.
Another interesting point. Nancy Klimas in Florida, she just got, I don't know the amount of dollars, but it's at least 6 and might be 7 figures to study Evusheld. How did she get that? I don't know.
From whom?
It's a federal trial.
It's a federal trial?
It's either federal or it's with the Cohen Group. I forget which.
And why if it's not FDA approved? I mean,
I don't understand it. And she's really smart, so she must have a good reason, because the reason it's not approved and available is that supposedly because the genetics of the virus keep changing, it's no longer sensitive to that.
Yeah, that's what I understood it to be. Yeah. But it doesn't make sense because long COVID, of course, were from different variants, not the ones that are current today, although they could very easily cause long COVID as well. But our current patients...
I think it's... Boy, we're off topic, but it's okay. I think it's an example...
I don't know if we have anyone listening anymore anyway.
I think it's a painful and sad example in science and research where a trial will be deemed a failure and the drug is thrown away into the garbage. Yeah. And actually, if you go back and look at the study, there was a group, if you stratified, that responded beautifully. And now you lose that data or you lose the drug.
Right.
So in the same way, yes, the viral genomics have changed to make it look like Evusheld might not work, but nobody's tested that. It might still do something, and that's what she's going to do.
Right.
I just don't know how she got funding for it, how she was able to convince funders and the government to give her the Evusheld.
That's amazing.
Call her and ask her, actually.
You should. You should find out more information on that.
Because it's really, I mean, knowing that would help us with the study we want to do, which is with a different monoclonal, with the same issue on that monoclonal. Also not available because the genomics changed. Genetics changed.
Oh, that's what viruses do, right? They change. They change it. That's why there are all these different variants. So, because they change their genetics.
Right.
But I do think it's important. So, yeah, I agree. So, are we suggesting that we should do chronic antivirals?
I'm wondering. The question I'm asking myself and us is, should the decision to treat with an antiviral be fully dependent on the level of suspicion of reactivation? Or should it be assumed that all of us have these viruses in us, and just because at one moment in time, 9:45 on April 2nd when the blood was drawn, I didn't have evidence of reactivation, does that mean therefore I shouldn't treat that patient?
Right. No, that's a good
Especially if
good
the drugs are reasonably well tolerated. So and literally that's one of my takeaways from this paper. Maybe I need to rethink that approach. Same thing with some of the other kinds of infections. So I see a lot of IgM positivity for mycoplasma and high serology antibody testing for chlamydia, no symptoms in the patient, and I will treat those pretty aggressively with antibiotics for the same idea.
Mm-hmm.
But I don't treat just IgG alone, all right? And maybe we should be. I mean, in chlamydia, it is just IgG, but I document a rising number. The point I'm trying to make and that we're making and discussing is, given what we're learning, given what we know about infection, should we have a much lower threshold to dive in with treatments?
Right. I think we should. I think this is where, once again, standard of care plays, an annoying role. Because in the sense of, like, if something went wrong, let's say, and you try to explain why you put a patient on chronic antivirals and you didn't have the labs to support it, then it wasn't standard of care, right? And so I think that's what would make a lot of doctors shy away from doing chronic antivirals. Yeah. But I also very regularly, and you've heard me say that we rely too much on our radiology technology in terms of imaging for our patient population. You can't always see what you believe is happening and want to see. I think similarly in labs, because of sensitivity and specificity and just the nature of certain assays and even the way they're performed, because as we know, a lot of those mast cell labs are notoriously difficult to get, and it requires a lot of technical care by a technician. I think that sometimes we rely too much on laboratory outcomes. And as you said, at 9:42 a.m., it might be different than what it would have been at 2:45 p.m., right?
I 100% agree with you.
So, and this is where, I think doctors sort of get, it's a gray area. And if you're not, I think everyone, of course, does their best, but I think if you're stuck in a 20-minute appointment at some institution, you don't have the time to sort of ponder all of this and sort of be willing to sort of come up with a plan for the patient. Like, I come up with the plans, I know you do as well, of like, all right, we'll put you on this medication and we're going to monitor. We're going to check your white blood cells. We're going to check your platelet counts. We're going to check your, sodium levels, whatever it may be for that particular drug that you're prescribing. We come up with a monitoring plan, and our patients are very compliant with that. So it gives me a sense of like, okay, I could just be sure that nothing of harm is going to be done. And usually nothing, I really haven't had problems.
But to your point, if what you're doing and I'm doing, what we're suggesting is outside the guidelines and outside the evidence-based medicine,
that's a good way of
those physicians who are employed in hospitals, clinics, et cetera, are not allowed to do that, right? Or they're afraid to. I mean, I can't tell you how many times I've had a patient say, she won't prescribe Valtrex because there's no evidence.
No evidence, right?
Or
no indication.
Or what's LDN? I mean, they just don't.
Right, and the other thing that I always point out, and then I say this about antibodies, but I'll say it about viruses too. We only look for what we know about, right? Listen, before 2020, was COVID? Were we regularly talking about COVID?
Exactly.
So who knows what viruses that are ubiquitous that we've been exposed to that we don't.
To this idea of low threshold to treat.
Right.
Because we don't know. I mean, for example, when I mentioned HHV7 before, turns out that LabCorp doesn't do HHV7 PCR and Quest does. Okay.
Right.
I use mostly LabCorp. I had a patient, it's actually a patient we share, who was using Quest. So I said, let me run HHV7. And it was really positive.
Wow.
I mean, not just positive antibodies. I'm talking about PCR positive. And then I started doing a few more, and I've seen more positives. What I haven't done, partly out of laziness, is have one patient go to LabCorp and Quest to get it. It's just so logistically more complicated.
Yeah.
And I've complained to LabCorp and said, please add this test. But my point is exactly what you're saying. Just because we didn't find it in a test doesn't mean it might not be relevant. Number one, because we might not know what to test for. And number two, maybe the lab isn't so good. I mean, going back to something you said even a little earlier just now, is it's bad enough that we depend on a snapshot to make decisions. But what about the fact that although LabCorp and Quest, which are basically the only labs really going here, I mean, people go to Mayo and Arup, but mostly it's those two. What if they're not so accurate?
Yeah.
What if their testing platform is not the best one?
Right.
And I've had, because I wrote an order in a certain way, sometimes I've had them run the same test. They ran it twice somehow, and I got different results in the same report. And it's like, whoa, what does that mean? That's a little goddamn scary.
Yeah, it is.
Yeah. Yeah.
It's concerning, right? Because we make clinical decisions based on results.
Exactly.
So I can't retest everything that I do to make sure that that number is accurate.
Right.
Sometimes if it's profoundly abnormal, like I'll say we need to retest it before I act upon this, because this is crazy.
Right.
But yeah, so we rely on labs, we rely on radiology, but it's what we have these days. And so I think just experience also plays a role, right? Just having done this for so many years now, I have a certain level of confidence on what I want to do and how I want to do it. And I just, monitor with the patient, and we come up with a plan and sort of see how it goes. But I agree when, I think this paper does suggest that we should try chronic use of antivirals.
And that experience you're alluding to is relevant to the treatment decisions. So
Right.
for me, with a drug like Valcyte, valganciclovir, that's a very, very potent antiviral drug, specifically for CMV and HHV6 and also EBV. I mean, again, I started using it during the HIV era, so I've been using it for decades, right? Initially intravenous, okay? So to me, what's the big deal? It's just Valcyte. I mean,
Right.
It's no big deal. And I've given it hundreds of times in the ME/CFS world, with virtually no complications. You go to a PCP working at Virginia Mason, they're going to look at you like, are you crazy? I'm not going to give you Valcyte. That's like what you use in transplant medicine to prevent CMV. I'm not going to touch that.
Right.
And it's partly just familiarity.
Yeah.
I know that it's safe to use as long as I monitor it.
Right.
And that's, again, that's the wall that our patients run into.
That is a wall. I mean, in some respects, I think it's a fair wall, right? I think there's
Yes,
a lot of
it is fair.
PCPs that won't prescribe some of the medications that are very regularly prescribed in neurology, right? So like they just don't feel comfortable with them.
Right.
And they go with the very, low-hanging like anti-epileptic medications, or even like pyridostigmine. A lot of PCPs don't understand that drug and won't prescribe it to my patients. And I never complain about that because I understand.
The problem is they're not going to learn it unless they try to.
Right.
And, I feel it's just such an unfortunate situation because they'll say, and they're right, well, I don't have time to learn it because I only have 20 minutes. And I don't have time to take a chance on it because if I do, then I need to follow up more quickly, and that's not possible because I'm booked out 8 months.
Yeah.
As a PCP, it's
yeah,
such a catch-22.
I know. I mean, again, the healthcare system is so broken.
Yeah.
It doesn't support chronic patients at all. But all right, so we do let's say chronic antivirals. What else?
Okay, well let's talk about this is a dance, right? Right? How many people are in it? Usually people dance together, right? So who's the other dance partner here? The immune system.
Right.
So the real challenge to me.
But what about the bacterium, though? Do you do antibiotics as well as antivirals?
I'm sorry.
No, that's okay.
Yeah, so
Yeah.
I'll use,
Okay.
as I say, for Mycoplasma and chlamydia, I will treat. It's a real challenge. Usually if they have, these are so-called stealth infections. They're difficult to eradicate, just like tick-borne infections. I've treated patients 30 days, 60 days with, doxycycline, azith, or chlorithro, because that's what works for those bugs. And the IgM goes away. Victory. 2 months later, I check it again. It's back. It's very, very frustrating.
Yeah, I've actually learned from you over the years so I now check for tick-borne infections almost all the time now.
Right. You're in
because
trouble.
when I've crossed over to the dark side.
You have.
Well, what I have learned the hard way, to be completely honest, in fact, one of the patients we share, we were just talking about this yesterday, because I wasn't the one who found his Lyme, right? But because I just wasn't yet at that point. But what I've learned is that when things don't calm down otherwise, that there's something else driving this, right? That you have to find. There's some chronic, simmering, maybe low-grade even infection.
Right.
And you have to go finding for it. So so now I have a lower threshold to go and check for those kinds, especially if the history would fit with exposure to ticks.
Exactly.
Yeah.
If the history is there. That is a never-ending mantra, chorus line, whatever the term is, of Tanya Dempsey and myself. If you go on Mastermind, either she or I, usually it's one of us and then the other one chimes in, you got to look for the infection. And it's true. It can cause mast cell. It can cause all these things.
Yeah.
It may have been there all these years doing nothing, but now the patient's not doing nothing.
Right.
They're sick as shit, and you need to look.
And their T cells are exhausted.
Right, right.
Exhausted. All right. So then they're the immune system. And I always say that in parallel, you have to do immunotherapy and some antimicrobial.
Exactly.
But antimicrobial, you can there are obviously the common ones. And
we got a lot of choices.
We got a lot of choices, but there are common ones that you choose from.
Yeah.
And I guess you could say the same about immunotherapy, though I don't really think so, because there's so many new ones now, which can never get approved by insurance. In fact, I just learned that one of my favorites is $160,000 a year if insurance doesn't cover it.
Which one is that?
Vyvgart.
Oh, yeah, right.
Yeah.
So I'm not even looking at the biologics and the fancy Jack this, Jack stat that, and all that. Well, because they're not accessible, and I don't regard those drugs as immune boosters. I think that they are modulating the immune system that might allow it to recover. So what? To me, this is the $1 million question. What can we do? It's the $1 million question because even if there is no ongoing antigenic stimulus, the damage is done, the deed is done, and that patient has hit bottom, all right? And that may be the cell danger response or whatever. How can we intervene immunologically given our limited tools? Both, do we have the tools, and are they accessible and affordable and safe? So I do think they're limited, but there are things we can do. Yeah. All right. And the first one now that comes to mind, because miraculously the FDA reversed its ban, is thymosin alpha-1.
Yeah, it's amazing.
We can
do peptides again.
It's unbelievable. And I just reread a lot of the literature over the last week or so on TA1. It's an incredible peptide. Yeah.
It really
increases, and the key piece.
But we knew that from when we were using it way back when lots of people responded.
I wanted to refresh my head. So. Right. So if you think about this paper and T-cell exhaustion, what does TA1 do? It increases natural killer cells, which are part of the T-cell population. Right. And it is antiviral. So it may be a way to deal with the antigenic side and the immunologic side at the same time. That is a tool.
That's amazing. What about the beta-4?
I think it has less of that activity, and it's more anti-inflammatory and helping with pain and healing. Yeah. And I'm sure there's others. I mean, you know more about peptides than me.
I love peptides. I love peptides. And I just recently learned that the FDA reversed their ban. I didn't even know. I didn't get the announcement. I got the announcement that they were putting a ban. I never got the announcement that they were lifting it. And so I'm super excited again to use my peptides. And I sort of have re-upped my research on peptides because there's a lot that has come out about peptides. Yeah. And I think that's part of the reason why. But
so again, just as we said a few minutes ago, or I said a few minutes ago, maybe I should have a low threshold, put every patient on antiviral trial just to see. Yeah. Maybe I should put every patient on TA1. It's not that expensive. It is not covered by insurance, so it is a cost. Right. It has zero side effects, just truly zero.
But it's an injectable.
Yeah, so you have a little tiny needle. It keeps you awake. It's no big deal.
Not everyone loves needles.
I've done it. It doesn't hurt. You don't even feel it.
Not everyone loves needles, David. You're right. But I agree. I'm actually, I'm going full steam with the thymosins. Okay. Yeah.
So that's one huge potential intervention. LDN is another intervention.
Yep. I put everyone on LDN.
System.
It doesn't help everyone.
No.
So.
And I guess we should add, when we talk about what can we do to boost immune competence, excuse me, there's things we can do directly, like TA1, and then there's just as important, anything that reduces inflammation will help your immune system.
For sure.
Too much talking, sorry.
You want some of my juice?
I got my water. What kind of juice is it?
It's apple, orange, ginger, turmeric, and garlic.
Whoa. That sounds pretty strong.
Talking about my microbiome.
I was going to say, am I going to be able
taking care of my
stay seated? I'll be flying out to the ceiling. Wow. Okay, so anti-inflammatories.
Anti-inflammatories.
My favorite of the day, obviously, is rapamycin. Increases autophagy. Yep. It improves immune competence.
I am getting such a great response on rapamycin.
Demonstrated in this brilliant paper from 2007.
I know.
I know. What is that? That's 15 16, 17 years ago.
There was a recent post that everyone's sending me about Brian Johnson, who decided that he was going to stop rapamycin. Right. Did you see that?
Yeah, I see.
Oh, yeah. So
well, I mean,
I always point out he's not a chronically ill patient.
Right, exactly. And what's the basis for it? I mean,
right.
All right. So if I tell you Elon Musk is taking rapamycin, does that help? I mean, It works, okay? It reduces
It definitely does work. And we're
inflammation.
doing it at a low dose, so I think it's very appropriate. It's fairly conservative, and we monitor. We do the labs, and
Yeah.
I have patients do those labs regularly to sort of make sure their lipids aren't out of control. And it works. It works. I mean, patients are reporting improved fatigue, improved pain.
Well, yes. I mean, it's incredible.
Yeah.
And in the trial we're doing, which will, by the beginning of January, go into phase 2. So we have whatever it is, 100 plus patients. We can see the changes in the proteins that document the change in autophagy, which was the hypothesis. Now we've proven it. And those patients that have the changes in their autophagy with these proteins, when they fill out the measurement tools, they're all improving.
Yeah. It's pretty
It's
amazing.
like pretty incredible.
Yeah. Did we get more funding for the next phases?
With bated breath.
Bated breath.
We need funding.
Yeah. We'll get the funding.
So I think somehow we're going to do it because it's too important.
It's
we
too
want to
important.
get more numbers. We actually partnered with a company to help us provide the drug and provide the labs.
Right.
And provide some additional research info. And Gunnar, Dr. Gottschalk, the co-investigator, and Avik Roy are adding some additional studies in their lab. I mean, it's incredibly exciting.
Yeah, it is exciting.
And a very easy drug to take overall.
Very easy, and just once a week. So,
Right. And yeah, so that's another immune competence intervention.
Yep.
LDN, TA1, rapamycin, exosomes.
Exosomes and
not
stem cells.
FDA approved.
The exosomes, no. The stem cells actually are under that right to try
Right.
program with the FDA,
Stem
so that
cells
helps a
can be
little
done.
bit. But yeah, I mean, both of them are showing. And speaking of the mitochondria, I mean, in the November issue of Mitochondrion,
You
which
didn't
is
send it to me. You're supposed to send me that paper.
I didn't send it to you. Oh no, I wish you would have reminded me. I would have brought it.
Okay.
All right, I'll electronically send. But in the November 2024 issue of the Mitochondrion, which is like the journal for those who do mitochondrial medicine, there is a remarkable paper about what we've known about stem cells and what I know that I've mentioned on these podcasts before, which is that they transfer their mitochondria to the damaged and dying cells. And they basically, it's like infusing new life, which is amazing. And so, and that's, I think, one of the most important mechanisms of action of the stem cell, of the autologous stem cells.
Right.
So I really am just super excited, and we work with Hope Biosciences, and they are really steeped in stem cell research, and I think it's the future of lots of medicine.
Do you think in properly matched, not autologous stem cells, it would still do that transfer? You seem to make it sound like only autologous.
Well, I don't know the answer to your question, to be honest, but as you know, the mitochondria have their own genome,
Right.
and the cells have a nuclear genome. I always say that I could be completely wrong, and I certainly don't want to in any way disparage like other practices, but I personally, because I do a lot of genetics, as you know, I personally don't think we know enough about the genome for me to be comfortable for my patients to do non-autologous.
Yeah.
And
agree.
exosomes, as you know,
I
are different
agree.
because they're just vesicles, they're not
Yeah,
cells.
that's why I do
right, which is
exosomes.
why I also do exosomes,
Right.
especially because they're quick, they're easy for the patient.
Exactly.
But that's just, again, my own personal conservativeness, which is funny to say that I'm conservative, but I am, as rogue as I am, I'm very conservative.
Well, I think
so,
I think it's because we're both well aware of how difficult it is to treat this population of patients.
Yes.
And how little data there is. I mean,
there is little data.
There is probably not a single drug that I prescribe that is on label. Everything is off label. So I'm already ready to be in front of the firing squad.
Exactly.
And so therefore we're conservative in the sense that we think it through, check the labs, et cetera,
Absolutely.
et cetera.
I ensure at the very least I do no harm. Right. So and that I could maybe predict potential side effects and counsel the patients on them and tell them, let me know if any of this starts to happen, and then we can just stop it. And and so that's sort of how I approach everything. But I tend to repackage and repurpose drugs that are already FDA approved for other indications.
Yeah.
And so we know a lot about them because, of course, for them to be FDA approved, the kinds of trials they have to go through are exhaustive in terms of like side effects and mechanism of actions and potential outcomes. So enough about the drug itself to sort of help really counsel and monitor the patient, even though you're using it off label.
Right.
So that's always, I often sort of start there, to be honest, largely because one, it's usually, well, not always, but covered by insurance. So I like to start with things that patients don't have to pay out of pocket for if I can, unless a patient says, I don't care.
Right.
So then I always add in the peptides and other compounding things that might have to be out of pocket. But I usually like to try to start with medications,
Sure.
even though they're, again, off label. And then if they're, and as you know, sometimes it gets frustrating because you end up spending months sometimes just like trialing and error with different medications and different dosings and different ways of administration of even the same drug. And at some point you just sort of say, we got to just be more aggressive on this. And that's sort of when I head into more of the regenerative kinds of approaches.
Right. But I've been rethinking that approach.
Have
too.
you?
Well, I mean, I do exactly the same
Yeah, I
thing,
know.
but then you turn around and 9 months has gone by.
Exactly. And the patient is still sick.
Yeah.
Yeah.
So,
I mean, we'll take rapamycin though, which is often covered, but if not very cheap. I am going there sooner.
That's what I'm
saying.
I'm ready to do it.
Right.
Potentially by the second visit after I've gotten the data.
I agree.
You know.
Right. I agree with that
just
completely.
Feel like,
in fact, even in my first note, I don't know if you've ever read my notes, but
I read your notes.
I don't know if you read my plans.
I read your whole thing.
Then you'll note that in my plan, I write everything we're doing today, which is usually a lot of workup for the most part. But then I'll start LDN and stuff like that. But then I write a bunch of like, consider this, consider that.
And that's my T/C.
Right. Oh, right. To consider.
Yeah, I do that.
One patient of yours asked me, what does he mean by TC?
It's funny that people don't ask.
They thought that you said tethered cord. He goes, does he think I have a tethered cord? I said, no, that's how he writes to consider. But so I write all these considers, and it's because at the second appointment is when I take all those considers and I start to implement them. And usually you'll see it now says rapamycin.
So as you said, we do rogue medicine. Another expression I like is cowboy medicine. But in fact, we do it very conservatively.
I think we do.
Yeah. And sometimes I think we err on the side of conservativeness too much, and we should actually consider intervening sooner with some of these more cowboy-esque.
I agree, because
drugs.
We see good response, which is, I think, the most important point we can make. Including plasmapheresis, which we didn't even mention, which has been phenomenal. And I think both of us have this sense of like, because we do charge for our time and we don't take insurance. So like there's a level of like, listen, I'm not just trying to make a lot of money from you. I just know these things have the potential of making you feel better, of moving the needle enough, as opposed to just trying a medication for a couple of weeks.
I would phrase that slightly differently and say, I know there's a good chance it can help, but it might not. But the chance of it helping outweighs the might notness.
Right.
And therefore, it makes sense to try it sooner, even though it's expensive also.
Right. That's a good way of describing it.
Because I've had patients get TPE, plasmapheresis, and not get benefits. So that's very upsetting, and I want to be very clear to the patients. But but that's not a reason to wait 9 months or to wait until nothing's left to try.
I agree with that completely. Right. And I think it holds greater promise over like, some medication, and I'm trying to come up with an example, but some of the more commonly prescribed medications for all these chronically ill patients that, I would say at this point, having seen now almost 1,000, I got a patient count the other day when I was transferring things, but of post-viral syndrome kinds of patients, that the majority of them didn't respond to sort of the classic
usual stuff.
Yeah, usual stuff. And that gives me motivation because I want to help them get well a lot quicker, to really, like you said, just to sort of move ahead. Let's just move ahead. Let's just move along,
So plasmapheresis is another intervention to potentially boost immune competence, immune function, by removing antigen garbage. Mm-hmm. That's what it does. It takes all the garbage out of your blood, out of your plasma. The garbage can be spike protein. It can be bits of this bacteria and bits of that virus and bits of this misfolded protein and all the schmutz that's mixed in your plasma.
Right.
All of which is stimulating your immune system and leading to
chronic antigenic stimulation. Right. Exactly.
And at the same time, the very process of removing it and giving you back albumin is anti-inflammatory and boosts immune competence. So it's one of the few interventions where we're dealing with both sides of the coin.
That's right.
Another drug is metformin. Cheap.
Very cheap.
2 billion people take metformin in the
But
globe.
Speaking of the microbiome, as we were talking about earlier, I mean, I do think it's got a lot of adverse effects on the GI tract.
Well, it can have side effects like, diarrhea and pain.
Right.
But there's evidence that the reason it works is because it also alters the microbiome. That's
right.
That's a benefit.
And are you seeing that in patients?
Well, I don't know how to prove that. I just seen the research.
But I'm saying, do their stomach symptoms get better?
I have very few people that have GI symptoms. You start low, taper
you do
it up
so much
slowly.
SIBO. Is that really true?
No, from metformin.
Oh, from metformin.
No,
I
from metformin.
I meant, so you don't have people that start with sort of
No, I treat their SIBO first.
Okay. And it's always a successful treatment for their SIBO?
No, definitely not.
Okay.
I mean, that you asked earlier, I forgot, we've been doing this a long time. You asked earlier about why do they recur?
Yeah, I have patients who can't get their SIBO treated.
Patients laugh at me, but it's because you don't catch SIBO. You didn't get SIBO going to Costco or Safeway. You have it because there's something wrong with you. Usually, it's a motility disorder.
Right.
You have dysautonomia. You have POTS. You have POTS of the GI tract. It's not working right.
Absolutely. But that's what I'm asking. So these patients, you put them on metformin. Does that improve? Do their classic GI symptoms that is recurrent SIBO improve?
I can't answer that. I never looked at it.
Well, that was what I was trying to ask, because I haven't seen that happen. So I worry that the metformin, because there's an additional GI side effect to it.
I guess the reason I'm not able to answer is that I don't usually give metformin to people who appear to be having lots of GI symptoms.
Okay.
Partly because it can cause GI side effects.
No, that makes sense. Of course, yeah.
So the real question is, am I giving metformin to people who have SIBO that's just not diagnosed and treated?
Right.
I hope I'm not, since I'm nuts about SIBO. It's not a treatment. It's not a drug I give in the first or second visit, because that's when I get the SIBO tested.
Right.
So maybe, that's really down the road a little.
That's a good point. Okay.
But metformin is a cousin of rapamycin in that it works in some of the same metabolic pathways and immunologic pathways with mTOR and AMPK and all of that, and that boosts immune function. So that's another one. The supplement urolithin A can boost mitochondrial mitophagy.
Yep.
All of which can improve immune competence.
Methylene blue.
Methylene blue is a really interesting one.
Yeah.
These are tools that we can use for that other side of the coin, for the dance partner.
Absolutely. Yeah, exactly. For the immune system, to help modulate it and to help keep it strong, and to make it less tired. Right. Less exhausted. And there's also the senescent T cells, right? Because T cells can be exhausted or they can be senescent.
Right.
And so there's that level of senescence, which has good and bad.
And that's why rapamycin is key.
Yeah, that's where I was going with that.
Because autophagy is the cleanup system.
Right.
It is our garbage can, our waste management system that cleans up the senescent cells that are producing cytokines, which are actually,
right. And that's the distinction between the exhausted T cells and the senescent ones, is that the senescent ones make too many cytokines, whereas the exhausted ones make too few. Right.
They just don't do their job.
Right. They don't do their job.
I've wondered about other things which I've not done. For example, Neupogen, GM-CSF. It's a chemical, a drug used in chemotherapy to raise white blood cell count.
Yeah, no, absolutely.
Would that help? I don't know. It's not as expensive as it used to be. It's a thought. What else is out there?
Oh, I've been looking at a lot of different other kinds of options for patients, and I haven't made definitive decisions on what I'm going to move forward with, but I've got a lot of things on my list that I actually wanted to one day go over with you and see if we'd be willing to sort of trial these on some of our more refractory patients, right? Because we both have them, and you just get so sad that all that you've tried doesn't really seem to help. But yeah, so there's a bunch of things that I'm not just yet ready to talk about.
Well, that's why I got interested in the growth hormone thing, which can do another episode. But,
yeah, we definitely should do an episode on the growth hormone.
That may be another way to intervene, not intuitively, not what you would think of as a way to intervene on the immune system, but I think it does do that because of some other things it does with respect to the microbiome. So there are definitely tools out there.
Yeah.
I think the availability of TA1, and I don't know how long it will last, but changes the game, meaning it's something we can just jump on very quickly. It's not a cure-all. I don't want to make it sound like a panacea, just like exosomes and TPE are not panaceas, but they're really worth trying. The beauty of TA1 is it's cheap compared to exosomes and TPE.
Right. It does minimize symptoms, though, the TA1. Yes. And the other thing, the other peptide I really like is the GHK, and it comes as a nasal spray now. And so for a lot of the brain fog symptoms, I'm finding that to be most effective, actually. Really? And I think it's because, well, if you think about the brain, of course, and all the glial cells, which sort of works as connective tissue of the brain, is sort of how I liken it to, because it's 90% of the brain is glial cells, and it's like a buffering system, which is what connective tissue often plays. And there's so much brain fog, and often often headaches and some other neurologic symptoms. I find the GHK nasal spray to be very effective for that. So, yeah, I think that's become another peptide that I use.
I was thinking GHK copper mostly for connective tissue.
It is for connective tissue,
right? But you're saying it has this other role for brain fog.
It does have another role for brain fog.
That's a nasal spray of GHK copper.
Yeah,
or just GHK.
Just GHK. Yeah,
Interesting.
It's
where
a
do you
nasal
get that?
Pure Pharmacy. That's where I get it.
My favorite place. That's where I get the TA1.
Oh, is that right?
Yeah.
Okay. Well, that's good to know. So we can both do Pure.
Yeah.
And they're a good pharmacy. I really like them.
Very good.
Yeah. And and there's a couple of other. Obviously, I've still been using the BPC 157, and then there's a couple of other peptides that I'm particularly fond of. But those are definitely my favorites and my go-tos for patients of all types. And as you know, you don't have to be an EDS patient to benefit from things that are good for connective tissue, because the other thing that we know about immune dysregulation and chronic antigenic stimulation is that there's ultimately a breakdown of connective tissue, right? Because there's so much inflammation. And in fact, it's that kind of cellular damage that I think further provokes the immune system. And that's why we sometimes see autoreactivity and therefore some autoantibodies that come and go, Right. Sometimes we'll see an autoantibody that's associated with a particular diagnosis, and we'll even treat the patient with that for that diagnosis. But then, eventually a year later, those antibodies are no longer present. And it's not because of treatment, because that's not how the treatment is usually. But at least for the examples that I'm thinking about. I'm sort of like being very vague here because I don't want to, that's a whole other episode to go into specifics of autoimmunity and autoreactivity. Right. But regardless, I think that the cellular damage applies to connective tissue. So there's degradation of connective tissue, and that leads, of course, to different alignments of anatomy. Well, and then we have the anatomical component.
And that degradation it's not like it just disappears.
No,
it doesn't evaporate.
It doesn't.
Now you have pieces of connective tissue floating around that shouldn't be floating around.
Right.
And guess what happens?
Yeah.
The B cell sees it, the T cell
That's
sees
right.
it. There's immune activation, maybe some T cell exhaustion, more crap and garbage in your plasma.
Mm-hmm.
So,
I know. Everyone just needs a cleansing. We'll get some sage,
So, some takeaways?
Takeaways.
So one of the
what are the takeaways? Okay. Because the truth is that I'm going to go out on the street, and who knows what I'll be exposed to. Like, what do we as humans do?
Well, I mean,
like, who are?
I guess that brings me back to something I threw out earlier and then dodged, which is how come I'm not sick and somebody else is?
Genetics.
Why? And we always say genetics, but I think there must be other reasons. It can't just be genetics.
There are other reasons, because the truth is that. I'm sure no one hears me. There are other reasons, but I think it starts with genetics, and then it's compounded by your exposure history.
Right.
Because we know there are cumulative exposures. Yeah, exactly. It's not just a 2-hit anymore. We know that it's many, many more hits.
Right.
And
stress.
Yeah, and stress, of course.
It is remarkable to me. It shouldn't be remarkable to me. That's not the word I want. It is actually sad how often when I take a history and I start asking stress questions, and I do it kind of cautiously because I feel it's a delicate area for patients, they all have these major stresses.
Mm-hmm.
The role of childhood stress and abuse in our patients is phenomenal.
Yeah.
And that's been well documented using those survey tools. And, even yesterday I had a new patient, and I kind of doubled back because there was something I wanted to get straight, because she was different from my typical ME/CFS or long COVID patient. And so I asked directly some questions, and I tend not to do that because I feel a little like...
Especially the first visit, I feel like I haven't yet gained their trust.
Right, exactly. And, she had clear childhood abuse. And once the patient's comfortable telling you, you hear some really horrible stuff.
Oh, I know.
And I think that's another distinguishing factor. So not just genetics, but it's nurture and nature. That stress dials back to the whole T cell thing, right? That's a hit. Stress is a hit. A nasty divorce is a hit. A death of a partner is a hit. A death of a child, death of a pet. These are all stressors.
Yeah, where it makes you start to think like maybe generalized anxiety disorder is really T cell exhaustion. Yep. Am I taking it too far now? I mean, no, seriously. I mean, if you think about all of the stressful hits that the immune system takes over the years, especially since childhood, maybe there is like a level of where there's an alteration of the nervous system, and you just have a lower threshold to have anxiety over things, or even panic attacks, or other kinds of mental health diagnoses.
Maybe, oh boy, this is really reaching. Maybe,
That's good.
maybe that's why benzodiazepines are so helpful to our patients.
Mm-hmm.
We say that we're giving them because they're mast cell stabilizers.
Right.
I honestly still haven't seen the data that proves that. It's just that that's what I've learned.
That's what
and
Afrin
told,
says.
and Afrin says. But maybe they're mast cell stabilizers by reducing anxiety, which may be kicking off mast cell activation. It has nothing to do with mast cell stabilizing. I have no idea if that's true. That may just be gibberish after speaking for 90 minutes here.
No, it's an interesting thought. I always assumed that the mast cells had GABA receptors on their membrane because they have so many
I'm
receptors.
Sure that's what Larry would say.
Yeah. But that is an interesting concept. Yeah. Okay.
All right,
some food for thought.
Yeah, and I think in some ways maybe we do an episode of why me and not.
I would love
him.
to talk about some of the
genetic
markers that I have, the variants that I have found over the years of doing genetic workups on these patients that help to answer that question, because we both get commonly asked that.
Right.
Like, my whole family had COVID. They're all well.
Exactly.
What's wrong with me?
Right.
You know? So.
Anyhow, going back to takeaways. So one takeaway is a very rigorous infection workup.
Yes.
Okay. And I would add an earlier consideration for empiric trials of anti-infective drugs and medications. So I'm saying infective meaning viral and microbial, viral and bacteria and parasite and the whole schmear. And I'll throw in another piece from HIV days and from tuberculosis days. Maybe one drug isn't enough. You know.
Interesting.
TB killed people, still kills more people than any other disease, I think, but was never treatable until somebody was able to show that you need 2 or 3 drugs to do it. That's exactly what happened in HIV. You know, everybody got so excited. We had AZT for HIV. Give it to the patient. Patient feels better. They rise like Lazarus. 3 months later, they're just as sick. Right. That virus, it's all evolution. You know, it's another one of those. It's evolution, baby. Okay? It evolves resistance. And then it became clear. But if you give AZT and a protease inhibitor and some other drug, the virus is trapped. It can't do it. It's outflanked. Go back to my battle model.
I love that, though.
You know, so and that's the approach I use for tick-borne infection. And maybe we need to be thinking that way in antiviral, non-HIV antiviral, and non-COVID or COVID too. Okay. Right. That's the attraction to me of this trial we might do with the monoclonal plus Paxlovid.
Yes, I'm super excited about this trial.
Yeah. You know?
If anyone wants to be part of the trial, let us know.
Oh, be careful what you say.
Well, it's going to start small. We're doing a small one first. But.
Okay, so that's a big takeaway.
Yeah.
And then it's the whole thing we just finished talking about on immune interventions in an attempt to augment the immune system by decreasing inflammation and doing things that literally boost it. And we got a lot of tools for that.
A lot of tools. I mean, you know, we've talked about immunotherapies before, and there's a lot of old guard ones that are cheap and generic and easy to do. Rapamycin is certainly one of my favorites, and then there's all the new ones that have a lot of potential but aren't accessible. So they do have a lot of potential, though. When I think about the tyrosine kinase inhibitors, like for example, and anyway, that's a whole other topic because we can go down the road of all those different immunotherapies that are now out.
Yeah, no, I agree. Definitely.
Okay. And then, and all the regenerative therapy. Well, we should actually come up with a different name for them because it's not about that we're not using them for the regenerative. I guess we are technically.
It is still regenerative.
Yeah, but it implies like the worried like longevity people who want to live forever.
It goes back to my talk at the MCAS meeting, which I think
I wasn't there.
I know. We missed you. I think that the huge explosion of knowledge in the anti-aging longevity universe is totally applicable to our patients with their chronic complex illness.
Right.
And we're talking about those drugs. See, everything I said about, almost everything we've said, metformin, rapamycin, exosomes, plasmapheresis, stem cells, that's part of the longevity world. And that's a big place of where it has grown and the research has come. It's interesting.
It is interesting.
It is applicable to our patients.
What's nice is that world has a lot of money.
Yes.
So they do a lot of research.
Right.
Yeah. They're very vested in trying to figure out how people can live to 120.
You know, basically what I would say is thank you to the biohackers because
Yes.
they have taught us so much.
Oh my gosh, that is true.
You know?
But because you said that, I mean, you have to be careful.
Of course.
Some of those biohackers are
nuts.
You said it best. Right. It's not always true or accurate or reliable.
Right.
So you got to be careful. Yeah. And I think we should, I mean, maybe one of the episodes we do is take what biohackers are saying on social media and either validate it or negate it or just give our opinions, you know, because I'm not into like fighting and wars. And I just feel like everyone needs to make their own decisions.
I think I want to get into a fight with
Yeah.
biohackers.
But we could at least
That's all
talk
I
about
need is
some
to
of the
have to
things
fight
that they.
with Greenfield or Rogan or those people. God. Bad enough you got me on Blue Sky.
That was my baby step. Beware.
Right, exactly.
All right. Well, this was a good conversation, actually, and it's a very long one.
I don't know if we should divide it into 2 episodes or just
I'm going to just
post it as
people.
a full
You know,
episode.
the nice thing. I mean, they could have done this on Patreon too, I suppose. But on YouTube, like you can just stop it. You can come back to it. You can listen to it at like 3 times the speed. Right. Although we talk so fast that I think that would sound like gibberish. But who knows?
Speaking of which, let's talk about YouTube and Patreon. Okay. First of all, the obvious thing you hear all day long if you watch YouTube, please subscribe.
Yeah,
okay?
Please subscribe
Apparently,
to YouTube.
it's all about the numbers to get more visibility for our
For the
channel.
algorithm.
Yes,
that's the fancy word that they use.
Because the reason we made this switch was to get more people to watch, more patients, more families, and especially more healthcare people. So anything you can do as a current listener, watcher, whatever you're called, subscriber, I don't know what you're called. Anything you can do to help get this more visible, we would really appreciate. So you subscribe, but tell some other people too, all right? Let them look at one episode. Let them watch this episode and see if they're interested. And then don't forget that we're not taking subscriptions to Patreon anymore. So apparently some people are still subscribing.
Yeah.
We'll refund your money.
I've refunded all of them
don't
thus
keep
far.
doing it, all right? We may do some stuff on Patreon. We may do something separate from YouTube, and for that, maybe there will be a subscription fee. We're still not sure. It's a question of how much time we have, et cetera, et cetera. I think the main focus is on YouTube and getting enough people to see it so it gets seen even more and more and grows virally.
Well said. Well said. We might do our lives on Patreon.
Right.
Although someone recently told me you can do lives on YouTube too.
Yeah.
So we'll see. Okay.
Yeah, I'm tired. Okay, thank you very much.
Yeah, thank you for listening. And yeah,
confuse
spread the word.
We'll post the paper title and a kind of neat diagram from it on YouTube if we know how to do that.
Yeah, well, you figured out that AI.
Yeah, I can do that for the picture. Maybe I'll use the diagram as the picture with some print. Oh, that's
a good one.
I have it.
That's a really good one. Okay. We're getting better. All right. Have a happy holiday.
Yeah, great holidays.